Hi, good afternoon. Bobby Hand and Dr. Barrett just wrapped up. Uh, I'll just talk briefly, give people a chance to kind of like stretch and move around. I'm going to talk about telehealth or telemedicine. There's lots of different words out there. Um, I'm going to approach this from kind of a pragmatic perspective. So I'm also at VCU. As part of the Movement Disorders Center, and I've been taking care of movement disorders patients and working in rare disorders for about 20 years now. And it's only been in the last year and a half that I really had the opportunity to do a lot of video or phone interactions with patients that were very structured. I've always called patients or answered messages. But it's relatively new for our institution to have such a large load of telehealth, although there has even well pre-pandemic been a push into this. So I wanted to talk kind of about how to take advantage of one of the few silver linings of this global pandemic and to use this successfully as part of your care. So when I've done stuff like this before, I've been able to type into the slides. I was warned that I wouldn't be able to do that here, but I'm hoping maybe, I think I can see the chat. If people want to throw in any words into the chat or unmute themselves for any words. If you've already attempted to use telehealth to connect with any of your providers, whether it's in neurology or not, what you think of that experience, or if you haven't done it and have some preconceived notions, to try to get a little feel for what people already have in their head as notions about telehealth. I can see a chat box.
It looks like our crew is a little shy today, so we want to encourage everybody in the chat to go ahead and play along with our word association game. So please let us know what your thoughts are.
I see. Thank you, Patrick. I'm told the chat that I can see is internal and doesn't go to the viewers, so it's possible there's stuff that I cannot see going into the main chat.
Okay, a couple words that have come in are Zoom, safe, no waiting, works well.
So yeah, no waiting, I think has a lot of appeal. Works well, I like to hear that. Safe, I like to hear that as well. So let's keep some of those things in mind and talk about here some of the potential upsides and downsides to using virtual visits rather than in person. A huge upside is that it can really remove a lot of transportation barriers. I've had people, especially on video calls, be able to bring a family member who's participating in their care but is currently not living in the same state or had to be out of town at the time of the visit. I've had a couple of both patients and family members joining in from a private location at work so that they're only taking an hour out of their workday instead of taking off a full day from work. Definitely from the most participant side, it's a faster, quote unquote, in-office time, partially because we're not doing some of the things like taking a full set of vital signs, blood pressure and heart rate, and standing and sitting blood pressure, and partly because there's less of moving about the clinic to get from the check-in clerks to back to a room. I just love seeing all the stuff in people's houses, and I've yet to meet any amphibians, snakes, lizards, or bugs, but I have met lots of vertebrates of all different kinds. So this can be pretty fantastic. Potential downsides are, for obvious reasons, we're not doing everything the same way, which can be okay, but sometimes we're trying to make care decisions that might be focused around impacts on weight, or impacts on blood pressure, data that's pretty basic that we're not gathering. That can just be a challenge. Many of my own family members have terrible cell phone or internet service based on where they live in the country. So relying on an affordable or even feasible link is not always the case. Whether it's on the video or on the phone, sometimes it's just a lot harder to hear each other and pick up cues. I long been in the habit of making and printing off the plan section that's going to go in my note and just handing it over so we can go through it. That becomes a lot tougher when I can't hand it through the screen. Making follow-up appointments, sometimes it's easy because the clerks who are also in their own part of virtual land are immediately available, but sometimes they're not. And then instead of waiting, you have to connect at a later date with them by phone. While we've all been on a fairly steep learning curve and relying on our colleagues, for example, at the Veterans Administration System or at other institutions that have a long history of telemedicine, even with training and experience, parts of the neurological exam in particular can be really challenging. In terms of PSP or other Parkinsonisms, I personally find it often really challenging to get a detailed feel of eye movements across video, whether it's my screen or the person's phone or computer they have at home. Often the video quality isn't very good for that. Sometimes it's really easy to see people walk, and sometimes it's not. A lot of the pen and paper cognitive stuff can take a lot longer or be harder to coach through in my personal experience. That's not to say that you can't still get quality, but it's to sort of think about how can we leverage the upsides and acknowledge and then work around or mitigate the potential downsides. So in terms of setting up for success, I think about before the visit, the key thing, as with all care encounters, is what you're about to do really is what you need. If you are on dose titration of a medication and a quick phone check-in to make sure that that's going okay and you don't have any questions and everybody is all right, could be the perfect match for your needs. But if you have a new acute problem and a lot of questions about that, and it's going to rely on a really close physical exam, then maybe you need at least a video, or maybe that really needs to be converted to an in-person visit. So what do you think you're going to need at that visit, and is the type of visit going to really match that need? Thanks to the pandemic, the rules are constantly changing in terms of what different groups can do or able to offer in terms of telemedicine. So for example, I know we're starting to pull away from phone-only visits as insurers stop paying for them, or they start paying for them at lower levels, or we start learning which patient populations the phone visit, we just figure out by the end of the phone visit the person really needs to come in, and that the phone isn't a good match for what they're doing. In some states still, there's a difference between the person, the patient being physically at home or the patient being physically in a clinic or a care facility of some kind. Right now, some of our providers, thank you, Dr. Barrett, for doing that recently, have emergency licenses to do telehealth visits with patients who are physically in North Carolina and not physically in the state of Virginia, for example. But the rules for those licenses are constantly changing as hopefully we're coming out to the far end of the pandemic. So there's just some logistical things to think about in terms of pragmatically setting up for success, as well as thinking about what kind of care needs you have to make sure that everything sort of comes together. Knowing who some of the other speakers were, they were all big believers in interdisciplinary or transdisciplinary care, especially for Parkinsonisms. But sometimes you don't need that. You just need to talk to your one provider, or you have something very specific with your physical therapist, and that's okay. So is this going to be a long interdisciplinary clinic visit that involves a bunch of different providers? Do they have a virtual platform that enables providers to cycle through while you're still there, or is that going to have to work some other way? It's just a regular, I should have put neurology or other office visit. And then I would road test the platform. Even if it's a phone call, I've had people call me from where they thought would be just fine, and then continuously lose their self-service because they thought, they could be a passenger in a car while they were doing their clinic visit, but that turned out to not really work. So, asking to check it out. Usually there's a clerical team that's very happy to, make sure that you take those 5 minutes and everything works fine. And then the basics that you guys have all thought about just to participate in this conference. The sound volume, is that going to be okay for you? The lighting. It's really nice if it's feasible to have another person there that can help. Some things we're able to sort of examine secondhand by asking for a little help. Sometimes it's nice for you as the patient to really be focusing on the interaction through the screen, or really listening hard so you can hear well on the phone, and have somebody else taking notes, or pulling your medication bottle so you can answer that question for you. And then look around ahead of time, especially if you're on video. Is there enough space for you to put your hands up, for somebody to see you? Could you get up safely and do a little walk around? Somebody kind of flip the camera for you. Like walking in balance is a really big component of what you need to talk with your provider about. And then a shorter total visit is one of the advantages for telehealth. Just being able to budget a little bit of time in the back end to talk to the nurse navigator, or to talk to the clerks to set your next appointments up, can be very helpful. Sorry, my phone went to sleep, even though they taught me how to have it not do that in order for me to have the clicker. So, so I wanted to keep this purposefully away from just 15 slides about telehealth. Keep it at a pretty high level in order to have lots of time to hear if there are specific questions, because just declaring something telehealth really covers a lot of ground, and to have us have a little more of an open discussion, especially since I know there's been a lot of informative slides and videos already in this conference. Give it just a little more air. So if my colleagues can help me out, if there's a chat or a way for people to unmute themselves to ask questions, do a little more of a dialogue.
I'm here with a couple of questions that have come in from the chat. First is, how can people go about finding a PSP specialist that is doing telehealth visits?
Yeah, so finding a PSP specialist doing telehealth, any provider, whether they're a PSP specialist or not, their clinic should be able to tell you what the telehealth platforms are. For example, do you have choices? I know some of the providers in our group use Doximity or Doxy, so you get a text on your phone and you just hit that link and then you're in. But most of us are using the Zoom-based platform where the clerks will set you up ahead of time so that you kind of check in. And there's these little breakout rooms that you get sent to. It's quite a nice system. Other places use other platforms. We are still doing phone visits, but moving away from that. Other places are not doing phone visits. So the key is to identify whatever provider works for you in general, and then contact their office and see where they're at. If you had asked me that same question 2 years ago, I would have had a very set answer and a really easy way for you to figure that out. But as a kind of positive reaction to the pandemic, a lot of the offices have really been almost month by month evolving and changing, often ahead of their ability to change their websites or to change their brochures, or to go to all their places that they're listed like CurePSP and change all of that. So now it turns into a little more legwork for patients and families up front. Find whatever provider works for you, and that if you're going to need to go in ever, then I would start with that person, and then see where their office is at, and be sure to just press to say, what are the current choices, and are there any timelines on those choices? Like, is something about to be offered that's new, or is something going to sunset as the pandemic restrictions are lifted?
Terrific answer. Thank you so much. Another person would like to know, how many virtual visits are okay before having an in-person visit?
Right. So I think that really depends on the individual's care needs, everybody's ability to hear. Some of my patients are very hard of hearing and find it very challenging. Right now, I'm kind of struggling because I can see a lag between my voice and my face just in this platform. So even if you can see well in the video, you might have trouble with that. And I think sometimes it's nice if there's going to be a challenging or a detailed conversation about long-term planning, or a clinical trial someone really wants to do but is feeling nervous about, that sometimes being able to come in person, and have those conversations where we have more of our social cues. We have, even with our masks on, we have more of our social cues. We have just a little more kind of professional intimacy is nice. And when you're really noticing that you're just not getting enough out of the physical exam, or the provider saying, I'm finding it hard to completely sort this out, that means you've been a little long in virtual world, it's time to come in. I certainly have worked with patients who have gone for 2-3 years doing all virtual visits, through platforms at other institutions, and are only coming in person because they've moved to the Virginia area and they're transferring their care. They want to meet with their team in person because we're new. So I think the only real insurance or kind of pragmatic constraint is that most insurers, including Medicare, Medicaid, don't count phone as in-person visits. So if your provider is, for example, making orders for a new assisted device like a cane or a walker, making orders for home health therapies, you often have to be seen in person within a set window in order for those orders to be valid. And then it's worth checking with your insurance if they accept a video telehealth as equivalent to in-person. Most of them do. And I've been writing a lot of those orders based on video, quote unquote, in-person visits. So that would be my only constraint if you're trying to really tick things along just on phone and on a video telehealth, to be careful about orders or care needs that might demand some form of in-person visit, even if that's video telehealth.
Thank you for that answer. So we have a surprise visitor. Dr. Christoph Diaz has a question for you regarding telehealth, and he's going to jump in here right now.
Perfect.
Hi, thanks, Jacqueline. Okay, can you hear me, Claudia?
Yeah. Hi.
Yeah. Hi. I was just wondering, when I talk to different patients that are in different states, as you mentioned, the pandemic has really created a lot of adaptability, a lot of flexibility in what's allowed, right? So you have doctors seeing patients out of states. So it's almost like a lot of the regulation have been relaxed for the need of the pandemic. And I was wondering if you could discuss a little bit, how do you think is going to go back? Once the pandemic goes away, are the regulation going to be challenged so the convenience of this expanded access of telehealth will be maintained, or are you afraid that it might go back to some of the difficulty of the past where there are more restriction in what type of telehealth can be given based on different states? I was just thinking about that as you describe this expansion. Maybe you can chat a little bit about that.
I think that it will. I think that it will go back to being more expensive and more of a hassle for the providers. It's just, if you and your institution are willing to take the time to get you licensed in multiple states across a region, then it's no problem, right? So in the beginning, you could just do whatever because people recognized that it was an emergency and they had to suspend a lot of the rules. And even now, a lot of those rules are back in place. So for example, with North Carolina, this is an extremely easy emergency license to get, very fast turnaround, no cost, super easy, but you still have to do it. Whereas previously you didn't have to do anything. So my suspicion is that once that emergency restriction is lifted, then our group could continue to see patients via telehealth who are in North Carolina, but whatever providers were doing that would have to become fully licensed in North Carolina as well as in Virginia. So, and I think that the regulatory bodies are going to point to the pre-pandemic times of, well, that's just what everybody was doing. I worked with a group in New York State that's doing a ton of telehealth with Parkinson's disease patients. Providers were foremost in multiple states in order to do that. So I think the regulators are just going to point to the fact that that's what people did and it was fine, and so you're going to have to do that again. It's also a challenge because it is still different state by state. Every single state has a different set of pandemic emergency rules. So, so I'm grateful that some of the people at VCU Health and regulatory have been keeping up with that for us, because it's a lot to keep up with. So I think that's going to change as well. I think the one thing that probably will stick is that it will matter where the patient and family are, what state they're sitting in their home, or what state the clinic is in, or if they can be home or in clinic. I think the idea that people can be at home will stick around, whereas previously some states like Virginia did really discouraged and the insurance wouldn't pay for in-home telehealth visits. I think that'll stick. That flexibility will stick. The flexibility of the provider to be different places. I know some of my colleagues in Atlanta were doing, a couple had to go to Florida to try to take care of an ill family member and did their telehealth clinic visits for the clinic in Atlanta from Florida, but that didn't matter because their patients were still in Georgia where they were licensed. So I think where the provider is will probably remain flexible, but I think the licensure rules for being able to see people in different states will tighten back up, and we'll just have to go through the process and the money to be licensed in different states. Although I would hope that that entire system would just collapse, because why do you have to have 5 different licensing boards and pay them and give them the exact same information for them all to agree on the same thing? I think we'll do it anyway.
Thank you so much for that answer. It was very thorough. One person would like to know your personal opinion. If you had the choice, which do you prefer, telehealth visits or in-person visits?
So speaking as a provider, I lean a little towards in-person visits because all of the different types of patients I see, it's really, really 95 to 99% of the information I have is the history and physical exam. There is some labs, there's some imaging, but most of the time it's very much that. And the more time I spend with someone in person, the more of them I can see, the more I can kind of see out of the corner of my eye what their family is saying, the more I observe their spontaneous movements, the more information that I have in those critical history and exam areas. I will say for patients I've been following for a while, I lean a little in the other direction because it's new information. I get to finally talk to the family member that I've never been able to meet before, but who's really critical for that person's care. I see immediately why they keep falling in the incredibly cluttered room with the 4 dogs. Or, it just sometimes just puts a little more joy into the encounter. And I get to see people who really I wouldn't get to see very often if it was 100% in person, because they're driving 3 hours one way to get to us, and that's really burdensome. So for some of my patients, I've gotten to see people that I would not otherwise get to see, who I've been following for a while. And back in the old days when the person was kind of transition out of the practice, it would just get too burdensome to travel. So, in a perfect world where everyone could come in their own personal helicopter and get escorted right into a clinic, I really rely so heavily on that in-person interaction. But I've just gotten to really enjoy the upsides, particularly with patients and families that I know well that I've been caring for a while.
Great answer. Someone else would like to know, how can you evaluate swallowing via telehealth?
That's a really interesting question. I'm really blessed to work in a big subspecialty clinic with a lot of different kinds of providers who are all really working at the top of their game. So I rely very heavily on Woody and Bridget, the two main speech language pathologists who are in our interdisciplinary clinics, to look at swallow anyway. So over video, I think I would find it challenging personally to feel safe doing much more than quizzing the person. Although I know that it is entirely possible to watch people see how they actually ingest and use different kinds of foods. I know Woody and Bridget do it all the time in the Huntington's disease clinic that I run over video. So I think in terms of if that's a key question and it really needs to be a virtual visit, to really have it lined up, what exactly is the main issue or issues? Is it managing saliva? Is it managing liquids? Is it managing foods? Is it managing pills? Is it just, it all seems a little wonky and you're losing weight, not sure you're getting in enough. And then go through that with the provider, you might be able to come up with good solutions just over video, or the purpose of that visit might turn into, do you really need an in-person assessment with a speech language pathologist, or do you really need something like a modified Barron swallow or a FEES study to answer the question?
Terrific. We've got a couple of minutes left, and we have some non-telehealth questions. Would you mind answering those for us?
Sure.
All right. Are there any in-home care agencies that you're aware of that are specifically for PSP patients?
I do not know of any in-home care agencies across the country that are specifically for PSP patients. One of the reasons is that PSP is a relatively rare disorder, so it would be difficult to have enough PSP patients in one small region to have a whole care team devoted to that. The flip side is that PSP is not the only rare disorder that I work with, that also many of these other disorders also benefit quite a bit from home health. So usually what I ask is if the home health agency has any experience with a number of different disorders that have very similar home health needs. So those include PSP, other Parkinsonisms, Huntington disease, even Parkinson's disease itself, which is not exactly a rare disorder. There's a home health agency that was working with the muscular dystrophy and ALS clinic here that had a lot of experience with those patients, but really hadn't gotten plugged into our movement disorders patients. But as soon as I heard that they've been a big part of the muscular dystrophy and ALS clinics for a long time, immediately started referring patients to them because they had an idea of how to just deal with rare disorders and deal with questions. And one other thing is that centers like VCUs or other centers nationally have people like Bobby Hand, like Woody and Bridget, that can be terrific sources for home health agencies. I'll talk to home health agencies myself, or Nurse Navigator Annie will talk to people, but all of our PT, OT, speech, nutrition providers are very happy to talk directly with their colleagues in the home health agencies. So sometimes, there really is only one, maybe two home health agencies who even cover the region that the patient is living in, and that's the choices, whether or not they've ever seen somebody with PSP before. But that can be fine because we can just say, look, all they have to do is pick up the phone. We'll talk to them. They can ask questions, and when people feel like they have that support, they're often really down for, learning something new and providing the best care they can to all the patients in their region.
Thank you. Someone else would like to know if palliative care is something that can be done via telehealth.
Oh, that's a really good question. I think so. The way my colleagues who are specifically trained in palliative health speak to me about it is that palliative health is a way of organizing the care plan around a specific set of principles that are the right fit for that particular patient and family. It's not about organizing the care plan around specifically around end of life or around a very specific timeline. It's a holistic form of care that has particular goals that are right for the needs of that patient and family for however long that care plan lasts, days, years, decades. So palliative care should be, just like all the other forms of care in care plans, terrific to do over telehealth and have very similar pros and cons compared to a regular neurology visit or a more traditional general internal medicine outpatient visit.
Terrific answer. Someone else would like to know, how do you prevent the risk of a UTI for someone who is bedbound?
Boy, it's been over 20 years since I was an intern, and the longer I get away from internship, the more dangerous I become. So I'm going to avoid that question because I'm going to give you bad information.
Fair enough. We have another question. Someone would like to know, is an osteopath recommended to manage neck or back pain as part of PSP?
So again, I'm going to lean on a bit of secondhand information. So I'm a medical doctor, MD. Many of my colleagues are DOs, doctors of osteopathy, and osteopaths. One of the best movement disorders neurologists I'm sure I'll ever meet, Stuart Factor, my former boss at Emory, is a DO, it's an osteopath. But all the people who are DOs versus MDs that I've encountered in academic neurology we're operating very similarly, and there are just some specifics to osteopath training that involve muscle and limb manipulations that I'm not trained to do, but I find it relatively unusual my colleagues who are DOs actually do that or incorporate it as part of their practice. And the vast majority appear to lean on physical therapy and other interdisciplinary colleagues for those care plans. But if you encounter a provider who's a DO rather than an MD, it's worth asking if they actively incorporate the osteopath practices into their specific practice, and if they themselves do those hands-on techniques. In my experience, that's relatively unusual.
Thank you so much for all of those answers and your presentation today. We're very grateful to have all of your insights and information. Well, we've come to the end of our conference, and at this time, I'm going to turn it over to Dr. Christoph Diaz, our Vice President of Scientific Affairs here at CurePSP. And again, thank you so much, Dr. Testa, for all of your information and your time today. We really appreciate it.